I've never done a Facebook Live presentation before, and so again, bear with me. My name is David Ryley, and I work at Boston IVF. Boston IVF is a infertility and fertility center based in Boston, hence the name, with many centers throughout New England as well as parts of the United States. And I have the privilege of working at such an esteemed institution, as well as helping patients, families, couples in their journey to build their families as well as preserve fertility. And it's an incredibly blessed kind of opportunity that I have. And so I'm going to start to see hopefully some comments come in. I see one from Alyssa. Thank you, Alyssa. Hello back. Appreciate the shout out. It's very nice. And I see Diana, again, another sweet shout out. That means a lot. And while I'm waiting for folks to perhaps send me their questions, which I am more than happy to answer, and I hope I can do a good and thorough job in doing so, let's start off with some of the myths. There's so much inaccurate and worrisome data that people read about on the internet and newspapers, talking to friends and families, perhaps all well-intentioned, but often not quite accurate. And probably the most common question I'm asked when I see a patient or a couple is stress causing my infertility, or is stress causing my inability to conceive, or perhaps is stress causing any treatments I'm pursuing? Is it decreasing my success? And the answer is no. And what controls your fertility, what controls your response to treatments, is not dictated by stress. And you're in good company, because everybody going through these journeys is stressed. So that's an important point to remember. And before I go into some of the other myths, I'm going to respond to my first question. And this is from Pamela. Hi, Pamela. And the question is, how can I learn if my body is still making viable eggs? That's a great question. If you are ovulating, so if you're not on any type of hormonal contraception, such as the birth control pill, and you're having regular periods, you're ovulating. So you are ovulating if you're having regular periods. About 20 to 30% of the patients we see, one of the reasons they're not getting pregnant is because they're not ovulating regularly, because they're not having regular periods. And that can be due to a variety of reasons. The more common known cause of irregular ovulation is something called the polycystic ovarian syndrome, which is actually quite common. And there's other causes that cause you to have irregular periods. For those women who are having regular periods or who are not, whether or not you're making viable eggs is reflected by what we call ovarian reserve testing. And ovarian reserve testing is basically a set of blood tests, and combined typically with ultrasounds, that will tell us whether or not you can respond to our treatments. They don't confirm whether or not you're going to get pregnant. They tell us whether you can respond to our treatments so we can help you expedite getting pregnant. And Pamela, since you're about to turn 38, I think it's important to have those tests done. Again, they're blood tests and ultrasounds, and that will provide reassurance for you that as you get older and as your window of opportunity to perhaps build a family is narrowing, that data is really helpful to assist you in determining whether or not you want to pursue therapies that are going to help you build a family. So those tests kind of tell us about the, quote, viability of your eggs and how you respond to treatment. I have a question from Alexandra. Hi, Alexandra. What is your view on adenomyosis? So for those who are uninitiated to this whole process. Adenomyosis is a condition of the uterus. And basically, without sounding too technical, the lining of the uterine cavity is what sloughs off every month and results in a menstrual bleed. And that lining can invade, so to speak, it can infiltrate the wall of the uterus. Women with adenomyosis, which is what that condition is, their uteri tend to be associated with heavier periods. Their periods can often be more uncomfortable. And when physicians do pelvic exams, the uterus has a classic kind of what we call boggy feeling to it. Adenomyosis is associated with higher rates of infertility, but many women with adenomyosis get pregnant on their own. But within the setting of infertility, oftentimes success rates are lower, and it requires special manipulation with hormones to help reduce the impact of the adenomyosis on the success of infertility treatments. Adenomyosis is not a reason not to pursue treatments, and it's not a reason to think you can't get pregnant. The majority of women with such a condition do get pregnant when they pursue infertility treatments. Some of the other issues we often hear people talk about include, I was on the birth control pill for many years. Is that why I'm infertile? Absolutely not. The birth control pill has no impact on your long-term fertility. Another common question is patients will think that the positions they have at times of intimacy need to be better, or they might need to keep their legs up after they've been intimate. No, don't put that kind of pressure or stress on yourself. The more pressure one puts on oneself during those moments, the more difficult those moments will be, and don't think that that's impacting your ability to conceive. Another common myth is that couples who are trying to get pregnant should hold back on their frequency of intercourse. The most common urban legend is that if they have intercourse every other day, typically in the middle of a woman's menstrual cycle around day 14, that will help keep the sperm strong and the semen more viable and increase the odds of conception. And actually, there's no data to support that. So obviously, individuals should have intercourse when they want to have intercourse. For the purpose of procreation, timing it in the middle of the cycle is the best time to do it. Using over-the-counter ovulation predictor kits will help facilitate that, but don't get into this issue where you have to have it Friday and then wait Saturday and then do it Sunday, because it should be every other day. That is actually not the case. So as long as you're having it mid-cycle and you're timing it with your ovulation predictor kit, it really doesn't matter how many times you have sex during that cycle. It should be done with spontaneity, as opposed to this rigid regimen that takes away, obviously, the enjoyment of the sexual act, and it has no role on assisting patients in conceiving. Another common question is patients wonder if they pursue IVF treatments, for instance. Are they going to have twins? Are they going to have triplets? We're actually decreasing those risks significantly. The way we have enhanced the success of our technologies, in particular, the way we develop embryos in the lab, for instance, the way we can identify which are the best and which are, for instance, the more genetically normal, we have really enhanced our ability to limit the number of embryos that need to be placed into a uterus, so that the risk of twins and triplets has markedly decreased. And that should not be a reason to be fearful of pursuing these therapies. Another common concern that patients have that make them somewhat reticent to initiate these treatments are side effects. And it's important to recognize there's very few medicines in this world that don't have side effects. The beauty of most of the medications we use, for instance, in vitro fertilization, is that we're just enhancing natural hormones that already exist in your body. So the medications we use to stimulate the ovaries, to stimulate the eggs, are naturally occurring proteins. We're just adding to those proteins. So for instance, there's a lot of medications you take, even in gynecology, that are synthetic. The birth control pill, for instance, is made of synthetic hormones. IVF preparations are not synthetic. They are actual proteins that are in your body. We're just adding to it. Certainly, progesterone, the hormone that is often used in IVF and is associated with some of the emotional side effects just getting pregnant naturally, especially in the first trimester when progesterone is at its highest. Yes, we are adding to the progesterone. We are therefore perhaps contributing on that level to some of the emotional side effects. But most of the emotions related to IVF and those types of side effects are the anxiety of the fact that patients are really, really hoping for this treatment to work. And that's why we offer, mind-body techniques, and we have our own mind-body center at Boston IVF. We offer cognitive behavioral therapies, acupuncture to help mitigate some of those side effects, most of which are actually induced by the fact that you're undergoing infertility treatment, not necessarily directly from the medications, although the medications are known to cause significant bloating that is not permanent. I have a question. Hi, is slightly higher temps after insemination A? And I don't see the rest of the question. Let's see, can I figure out how to see the rest of that? I don't see the whole question, but I'm assuming it's asking if you have a slightly higher temperature after you've undergone insemination. Is that a good sign or a bad sign? It's a good sign, because typically progesterone, the hormone that you produce after you ovulate and occurs in the second half of a menstrual cycle, meaning if you call a menstrual cycle 28 days, there's the first 14 days and there's the second 14 days. Those second 14 days are associated with the progesterone hormone that's produced when you ovulate, and that is known to raise the temperature to a small degree. So if the rest of that question was, is that a good sign? Yes, that is a good sign. Some other typical questions we see as we wait for more to come in include questions about habits and do I drink too much coffee? There is the key for anybody trying to conceive and ready to build a family is moderation is key. And what's interesting is when we advise patients to be moderate on things like coffee and whatever vices, so to speak, they may have, we're pretty much saying what your primary care physician has probably said for your whole life. So moderation is key. I think to go overboard, to try to eat the perfect diet, to limit the amount of coffee one intakes or completely, eliminate alcohol is going overboard. And it's giving one the sense that they have control over getting pregnant. And you don't have that level of control. And then when you try to manage it on that kind of level, you're adding stress. And we've already mentioned that it is already a stressful process. So the point is, no, coffee in moderation is fine. And there's no data to suggest that, 1 to 2, 3 cups a day is going to be adverse. Alcohol, obviously, in moderation is fine. Typically, obviously, once you get pregnant, it should be limited, but one doesn't want to just have to go cold turkey. If they want that glass of champagne at the bachelorette party or they want a glass of wine with dinner, moderation being the key. So typically less than 3 glasses of wine or the equivalent per week is what's recommended by the CDC, and that's obviously a good idea. The worst insult and vice anybody can partake in that's going to impact their ability to conceive, not to mention the fact it's going to impact the health of a pregnancy, is smoking. Smoking is a really bad actor, and I think Anybody listening on this talk already knows that. They don't need me to tell them that. But smoking really diminishes one's ability to conceive and the health of a pregnancy. So if there's any incentive for patients who do smoke to stop, it's the desire to have children and get ready to start having a child. Um, Patients often read online or books or talk to friends that there's a special diet that will enhance their fertility. I do not know of that special diet. Certainly, you don't need me to advise you on the fact that we should all be eating, well balanced, high protein, low fat, good percentage of carbs diet, the ones that are provided by the FDA for years or the CDC, and those diets are good enough. There is no special foods. I think when we suffer from being overweight, which we do know is a significant epidemic in the US, that might impact your ability to ovulate regularly. And when it does, okay, then it's impacting your fertility. And certainly, if one is significantly overweight and one gets pregnant, it does increase the risk of certain obstetric complications, things like gestational diabetes, along that nature. So, the manifestation of being overweight, which may be the result of a bad diet, will manifest itself with irregular ovulation, and that can increase the risk of infertility. Patients who are severely underweight, who limit their caloric intake, is kind of the opposite end of the spectrum, that low ingestion of calories could again impact their ability to ovulate regularly and then in turn impact their ability to conceive. So at the extremes, when there's significantly a deprivation of calories or one is overeating and that results in extremes of weight loss or weight gain, that can impact fertility. But there really is no perfect diet, perfect exercise regimen, perfect vitamin. One should stay healthy and do things in moderation. I have a question from Jen. Jen mentions that she's healthy and she's 43 and she's done 2 cycles so far with no luck. I think the question that she's asking is, when do you stop? Is there a max? Well, let me give you the data and then let me give you the good overview. The data tells us this, that if you're 43 and we measure your ovarian reserve, and for whatever reason you need IVF to overcome your infertility, pretty much up to age 44, the data supports, as long as that ovarian reserve testing is in a normal range, the data suggests that we're increasing your odds of conceiving over what nature confers to you. So on a data level, yeah, through 6 cycles, up to the age of 44, we're increasing your odds. That being said, a lot of patients, as we mentioned earlier, this is psychologically, it's a challenge. It's not for the faint of heart, so to speak, and a patient may not want to go through 6 cycles. And what I always ask all my patients before we start a next cycle is I say, how are you doing? And if a patient psychologically is not ready to continue or wants to do something else, that's the time to consider an alternate approach. So data-wise, certainly through 6 cycles, there's data to support doing it as long as the ovarian reserve testing has stayed normal. But if an alternate approach is required because the patient is psychologically exhausted, that would be a reason to consider something like donor egg as an alternate way to build the family. It's tough to get pregnant at 43 when you have infertility. It's not easy, but certainly we have plenty of patients who are successful. Some do require donor egg, and it's rare that I can imagine a scenario where I would do more than 6 cycles. Um, Melissa, Melissa, thank you. She's a wonderful patient who I'm thrilled for she and her husband, and congratulations. I've heard through my cousin that you're doing great, so congrats, that's awesome. I have a question from Amy Lynn. She mentions that she was recently diagnosed with PCOS while trying to conceive her second baby. After 3 rounds of letrozole, which is a pill for the uninitiated here that helps induce ovulation, we will be moving to our first insemination cycle. Can I touch on what to expect? Sure. So basically, easy for me to say. I know I'm a guy, but I've been doing this for 30 plus years, and 99% of my patients mention that an insemination feels like a pap smear. Some women have more cramps from it than others, but the vast majority, it's not complicated. So basically, what will happen is likely your ovulation will either be monitored at home, or more likely, you'll be given a trigger shot when your monitoring suggests it's time to ovulate. You'll take the trigger shot, and 36 hours later, you'll come in for your insemination. If that involves a male partner, he will bring his fresh semen specimen. The lab will prepare the sperm and concentrate it in a syringe, and the medical person who's doing the insemination will place a speculum in the vagina. The syringe is placed in your cervix, and the processed sperm flushes into the uterus. And again, the vast majority of my patients say it feels like a pap smear. It will only take a couple of minutes. There's actually no restrictions on your activity. If you're using a sperm donor or your male partner froze his sperm, the sperm is thawed and the same thing happens. If you're looking at the data in the natural active intercourse, 100 to 300 sperm make it into the tubes to fertilize an egg. With insemination, it's 1 to 3 million, so it's a very efficient process. And Pamela, you're welcome. I have a question from Tara. I'm 40 and she has what's called the diminished ovarian reserve, which basically means, like many women, actually up to 50% of women at age 40, means that the ovarian reserve is at the point where you have to use a high dose of medication to affect a response from treatment. And she's trying for a sibling and for her daughter that she delivered a year ago. This is now my second cycle after pregnancy that I'm trying for this sibling, and I'm on the microlupron flare protocol. Is this the most aggressive? There's no such thing as the most aggressive protocols, and there's no perfect protocol for any particular patient. You have to try it and see what happens. So there's the ones that are the most aggressive use a combinations of medications that cause your hormones to flare with the injections you take. Another type does it a different way. They're both equally aggressive, and you don't know which protocol is the best for you until you've seen how you respond and you try another. The variability in responses in one patient of one protocol to another or between patients is quite amazing, especially as you approach age 40, especially as you do have a diminished ovarian reserve. So utilize the new protocol you're doing as a chance. Okay, let's try this. Since the last one didn't work, how's this going to go? So I'm sure because you do have a diminished ovarian reserve, the protocol you just went through was aggressive. This is another approach that you might respond better to, and I wish you the best of luck with it. I have one from Alyssa. If we had an IUD in our teens and early 20s, could this impact our fertility? No. Way back in the years when, in the 70s, there was a type of IUD that was used that did impact fertility. It caused pelvic conditions that really could impact the ability to conceive because it could cause scarring in the pelvis. Those IUDs are not used anymore and should not have any consequence for future fertility. Norky wants to know how many cycles of IVF do women regularly go through before they successfully conceive? Is it similar to IUI? Okay. It's hard to answer that question um, very succinctly because every woman or a couple that comes in has a different cause for their infertility, and every woman or couple comes in is at a different age. But the bottom line is this: insemination for patients who ovulate regularly increases their success, but nowhere near to the degree that IVF does. Depending on a patient's age, it takes less IVF cycles to conceive than um, it might be if someone's older. So for younger women, it takes less IVF cycles. For older women, it might take more. But again, so much of it is predicated on the ovarian reserve testing, which predicts how a patient responds to the treatment. In general, I would say that if you're under 35 and you're undergoing IVF, and particularly all your hormone tests look good, I'd say the average number of cycles it takes to achieve success is between 1 and 2. That would be an average. So many do it in 1, many do it in 2. For women, say 35 to 38 might be a little bit more, although our success has really increased it, so not so much more. Over 38, maybe more typically 2 to 3 cycles to achieve success. So dependent on age, dependent on diagnosis, and dependent on the testing. Another question from Diana. Dr. Ryley, how long after giving birth does one have to wait for another transfer? That's a good question for your obstetrician because they're going to have more of a say in it than we do. But the general guideline is if your pregnancy was uncomplicated, if you delivered vaginally, and you're planning to wean from breastfeeding, then it really is only 6 months. However, if the pregnancy was complicated for whatever reasons, maybe there was a significant blood loss at the time of delivery and you're still anemic, maybe there was a difficult C-section, or maybe your blood pressure was complicated. I'm not trying to scare people about pregnancy. It just, all pregnancies can end differently. It might require 12 months, and again, with the intent to wean. So typically C-sections, I think your obstetricians want you to wait 12 months, vaginal delivery 6 months, assuming no other superimposed complications. Certainly for older women who've had a C-section and the obstetrician recognizes that their window of opportunity is narrowing, they probably won't make them wait that full 12 months. Alita wants to know what I think about Mini-IVF, which is basically using minimal doses of medication for women over 45. Is it lower cost? Is it higher success? In my opinion, there's no increased success, and this is including a pretty good review of the literature. Once you're at age 45, if you're still ovulating, you can get pregnant on your own. It's just pretty low, probably in less than 5% range. It could be as low as 0 to 2% range. And any treatments we would offer, whether it's medication when you do with an insemination or whether it's IVF, the success rates are no different than natural conception, natural attempts. So the only real thing that medicine has to offer in that age group is using donor egg. That doesn't mean one can't get pregnant on their own. It just means we're not really helping it. I've had patients with similar queries who'll say, I would like to try IVF, and I will tell them that I'm not going to increase their chances. And then a year later, they said they had a baby, and they feel like I told them they couldn't. And that's not what I'm saying. I'm not saying they can't have a baby. I'm basically saying that my treatments aren't going to change the odds. So the answer to your question is no, I don't feel that Mini-IVF is going to make any difference over natural conception. And in my opinion, it wouldn't be worth the cost. And that's an ethical conundrum for a physician. I don't want to charge patients for something that I have no data to support. Marilyn has a question. She wants to what's called PGS test her embryo, but I just want to test 2 of them. My first cycle was successful. So now I will have to do another, but I will love to know the gender. Can I just take 2 of my 4 to test? or do I have to test them all? So, so what Marilyn's asking is looking at the chromosomes of the DNA makeup of her embryos. We all know that all our bodies, our cells have 46 chromosomes, and within each, it's where our DNA is packaged. Within each cell, 23 come from our mom, 23 come from our dad. So to make a normal human embryo, the eggs need 23, the sperm need 23. And when the embryos don't have a normal number of chromosomes, they tend not to implant, or they miscarry. That's basically why we miscarry, the most common cause of miscarriage. So it sounds like what Marilyn's asking is she has surplus embryos from a previous IVF cycle. Can she test those embryos for two purposes? One, if she checks the chromosomes, she'll have a higher live birth rate, presumably, and she can transfer one without having to take the risk of twins, because when the embryos are not tested, not both of them are necessarily going to have the same rate of implantation. So she's trying to get a higher chance of a live birth with the transfer of one, and she's hoping by looking at the chromosomes she can assess gender, which you could do. The difficulty with what you're asking, Marilyn, is sounds like these embryos are frozen from a previous cycle. To test these embryos, you would have to thaw them, and you'd have to remove a portion of the cells that develop into the placenta to check the chromosomes, and then you'd have to refreeze them. So you're putting those embryos through a lot to get your answer. You're thawing them, you're sampling them, you're refreezing them, and then it's going to take a couple of weeks to get the results back. And we do have data that was published out of our institution, and I have many patients who do this, by the way, so I don't want to say you can't do it, but we do have data to suggest that when you put the embryos through that, you might be lowering the live birth rate from the subsequent transfer of those embryos. And it's always better if you're going to check the DNA of the chromosomes of embryos to do it before they're frozen, as opposed to thawing them and then refreezing them as you wait for the results. And your question about can you take 2 of my 4 to test, or do you have to test them all? It all depends on how they're packaged. Typically, when you're freezing embryos, they're frozen at a stage of development when they're 5 days old or 6 days old, and they're packaged each in individual vials. So you don't have to thaw all at once, although the questions you're asking certainly have certain inherent costs. You know, how many you're going to thaw, and refreezing. So it's kind of a complicated question. It's preferable to do this before you have frozen your embryos. Kelsey, is it possible for progesterone injections to leave permanent nerve damage? Nothing in medicine is impossible. I have never seen it, and I'm assuming that if a needle is placed in the wrong position, theoretically that could happen, but I've been doing this for 30 years and I've never seen that. So I think that risk is very, very low. Can Dr. Ryley, this is from Laura, go over the medications a woman will take prior to IVF? I think when you mean prior to IVF, I guess you're meaning before you take the injections. So to briefly review, every month a woman ovulates, her body produces a hormone. The more common one that is well known is FSH, the follicle stimulating hormone. So when you hear us reproductive endocrinologists say follicle, we're talking about eggs. So every single month, there's a group of eggs that are ready to ovulate. So on your own, when you produce your FSH out of the group that's ready, one egg gets released, the rest die off, and what you're doing with IVF is saving the eggs from dying off. The important point I'm making there is you're not depleting your egg supply, you're saving the eggs. In preparation for that cycle, which I think the question is, Laura, oftentimes you have to go on the birth control pill. And the reason you go on the birth control pill, it's suppressing your body's production of those very hormones. So when you come off the pill, your body's been cleared of those hormones and it's not interfering with the dose of medication we're giving you to make those follicles and those eggs grow. That's one way of doing IVF. Sometimes patients have to take an estrogen patch as they go into the IVF. So that's typically what you take. There's also a medication called Lupron, which is given. as a shot that also is meant to clear out those hormones so your body's not interfering in the medication that's being administered. And that segues perfectly into Amy's question. The question is, why was I prescribed estrogen prior to starting the stimulation medication? It's another way of what I just described. So what estrogen does, it suppresses your FSH hormone. It's kind of clearing your system. But in many women, the estrogen itself makes the ovary respond better when you start the injections. So that's why it's done that way. Sarah, congratulations. That's great to hear. You're very blessed, and a 2-year-old boy is a handful, and you still sound happy. So sounds like it was worth it. Another Sarah asks, how does weight, obesity specifically impact fertility? That's a tough question to ask precisely when one's weight changes the hormone environment, so one doesn't ovulate regularly, it's definitely impacting fertility. If one doesn't ovulate regularly, one's not going to get pregnant, or one is less likely to get pregnant. And so 20 to 30% of the patients who present to my office who are having difficulties getting pregnant are not ovulating regularly. That's one of the main causes. If being overweight has not impacted your ovulation, it's probably not significantly impacting fertility, so to speak. But if a woman is infertile and she's overweight, whether she's ovulating regularly or not, it does impact the success of IVF therapies. I published a paper with one of my fellows about 5 or 6 years ago that really took a look at the impact that being overweight had on the success of IVF treatments. And we saw with each increasing weight category, the body mass index categories, there was lower success rates from IVF. And we looked at every parameter we could. We looked at embryo quality. We looked at how they responded to the medication. We looked at the dose of medications. We looked at their ages. We took all those things into account. And there was a 68% lower chance of success in patients who were morbidly obese. But with each increasing weight category, success did decline. So we do have more concise data on the impact the weight has on infertility, not so much directly on fertility itself for patients who are trying on their own, unless it's preventing regular ovulation and irregular periods. Lauren, 2 healthy, beautiful children. Again, like the previous shout out, those exclamation points sound like you're happy, so that's very cool. That's great. Congratulations. Thank you, Barbara. I should have you guys write press reports for me. This is amazing. So one from Kim. How long should you wait before seeking assistance for a second child? We have a 19-month-old science baby and have been trying for baby number 2 since July. Well, if it's since July of 2020, hang in there. It doesn't sound like you have to worry about it, but if it's since July of, or 19-month-old, sorry, 19-month-old baby. Basically, for women under the age of 35, if they've been attempting conception for 6 months, it's perhaps good to be proactive, but definitely if you've gone 12 months, concerns are you might now have infertility that would require assistance. Kim, since it sounds like your first baby required infertility treatment, as you say, a science baby, even though we all hear those stories of women who were infertile, they underwent infertility treatments, they had a baby, and then after they were done, they were able to conceive. Those are anecdotes, and usually when science was required to conceive the first child, it will be required again. So I wouldn't wait too long. I certainly wouldn't wait more than 6 months. And definitely if patients are over the age of 35, I wouldn't wait more than 6 months. But unfortunately, once infertile, typically infertile, and despite those stories we hear, they tend to be anecdotal. From Nicole, does a LH surge mean you ovulate? Yes, an LH surge will mean you ovulate. The LH hormone makes it happen. To confirm it, so to speak, you can always get a progesterone level, but if there's a clear surge, getting a progesterone test is unnecessary. It does mean you ovulate. From Erica, I miscarried in February. Sorry, Erica. Miscarriages are brutal. Um, on 7 months of trying to conceive with no luck. Have an upcoming appointment at Boston IVF. What can I expect? You know, the initial visits, and this is easy for me to say. I'm a physician and I'm used to it and I'm a man, but the initial visits aren't as bad as you think. And certainly, my God, in the land of COVID, there's no physical exam at the initial visit. And typically, I don't like to put patients, even pre COVID, through physical exams because I think that adds a level of invasiveness and intensity that really takes away from that first visit. And I can get 90% of the information I need from taking a good history and ordering blood tests. So don't worry about a physical exam, but the history taking is going to look at your pregnancy history, what occurred at the time of your miscarriage, looking at your previous medical history, hospitalizations, medications you might be on, your surgical history, and similar to your partner, if a partner is involved in this situation, looking at his medical history, whether he's proven his paternity in the past, and looking at both of your genetic histories. So it's a lot of talking, and I would make the argument that my nurses would definitely make the argument that I talk too much because I really might confuse the patients. But that history taking is so important because then that's going to direct where you want to focus um, your studies that you're going to do between the first visit and the second visit. And so I would recommend that you send any records you have, particularly related to that recent miscarriage, to the office prior to that visit. That's going to help facilitate your doctor's understanding of it and his or her discussion with you. And basically, after that history taking, tests are going to be ordered. And typically, and again, it's not the same for everybody, but typically, you're going to be scheduled to have blood tests. And those blood tests are mostly hormone tests. And those hormone tests are the ovarian reserve test that will determine, okay, to what extent can we help this couple get pregnant using their own eggs? That's the ovarian reserve test. An anatomic survey is going to be done. Typically, that anatomic survey involves taking a picture of the uterus and the tubes when you're flushing a water-based dye into the uterus so you can make sure the tubes are open and that the uterus is fine. And definitely you need to schedule a semen analysis for the male partner. So even though you got pregnant, you want to confirm that he does have sperm. And in addition to confirming that he has sperm, doing genetic testing on him and you to make sure, number one, you're not at risk for miscarriages over the expected risk, as well as other preconceptual genetic screening tests that you do to assure the health of the fetus that you might be creating with the next pregnancy. So that first visit is taking the history and then scheduling tests. No tests in that first visit. It's basically conversation, and it is stressful because of the anxiety related to this, but in the end, it really isn't. And the stress is going to be alleviated when you realize we're scheduling tests, and at the follow-up, you'll have all the information you need. Barbara, oh, excuse me, Sarah. Oh, that's a reply to another comment. Ralu, the answer to your question about being 42 and having irregular periods, does this mean you're no longer fertile? It doesn't mean that. But it does mean at 42, whether your periods are regular or irregular, your fertility is starting to decline. And we really see a significant decline over the age of 40. So if you saw a specialist like myself, you'd have blood tests, ultrasounds done to determine why your periods are irregular. And if there's a hormone imbalance, but there's still signs of good egg production, all you need to do is manipulate those periods with hormones that make you ovulate regularly. and that can be done either with simple medicine or IVF. Or if the irregular periods are because your ovarian reserve is declining to the point where you don't have good quality eggs, that would also be determined. So the answer to your question is, at age 42, whether you have regular or irregular periods, it's harder to get pregnant, but it does not mean you are no longer fertile. When would progesterone supplements, and this is from Nene, I think this is another question, I think you had one earlier, when would progesterone supplements be used after insemination? Lots of times we do it because we can. It can only help, it can't hurt, and progesterone helps support an early pregnancy. Certainly they might be helpful for women who tend to have rather short second halves of their menstrual cycle. Those are called the luteal phase. So from the time they ovulate to the time their next period, if that phase is short, oftentimes we help give them progesterone because that means they might need it. So it can never hurt. It might help. It doesn't necessarily have to be done. What can I tell my wife and I about starting reciprocal IVF? I assume you mean partner-assisted reproduction, and that's where a same-sex couple can use embryos derived from one member of the couple to be transferred into the uterus of another member. So there's a donor and there's a recipient. It all depends on who's donating and who's the recipient. The bottom line is you typically want the egg donor to be creating embryos, the egg donor to be the younger one who's more likely to produce more. And as long as the recipient has a healthy uterus and there's no signs that she would have any problems carrying a pregnancy, basically you create the embryos and then you time the thaw of those embryos to the ovulation cycle of the recipient. So we monitor her ovulation, she takes a trigger shot, and we transfer the embryo. So I like to do it separately. I like to create the embryos and then prepare the recipient for a thaw cycle. It's important to remember that the vast majority of the time, this type of treatment is not covered by insurance, but there are certain circumstances in which it is. And it's a wonderful way for patients in same-sex relationships to share not only the genetic contribution to their children, but also the biologic connection conferred by a pregnancy. It's pretty rewarding and pretty impressive. With an IUD, this is from Deanna, with an IUD placement, could you tell if a patient has an underlying medical condition such as the polycystic ovarian syndrome, endometriosis, etc., or should the IUD be removed to know for sure? Somewhat of a complicated question. You don't, if the type of IUD that is placed is preventing you from having periods, yeah, you can't see the regularity of the periods, but many women with the polycystic ovarian syndrome, for instance, have an IUD placed, so that's why it's in there in the first place, so they may have already been diagnosed. And many patients with endometriosis, because they have painful periods, will have an IUD placed because the IUD will prevent regular periods and cause less pain. So many patients have the IUDs in for that reason. Yes, you can tell if a woman has endometriosis if she has an IUD in because you have suspicion based on ultrasound, and that suspicion might often lead to whether or not a surgical diagnosis needs to be made. And typically the polycystic ovarian syndrome, you can make the diagnosis with a combination of ultrasounds and blood tests. You really don't need to see the menstrual regularity. So yes, you could make that diagnosis with an IUD in place. Thank you, Barbara, for the compliment. I'm going to turn red. One patient asks is how many cycles of insemination are tried before IVF? It all depends on the situation. Let me give a classic example. So if a couple's diagnosed with quote unexplained unquote infertility, which 25% are, that's where all the hormone tests are good, the patient menstruates regularly, her anatomy is perfect, and the male partner's semen is normal, and they're not getting pregnant. And if science can't identify why, it doesn't mean we can't help. So when you have unexplained infertility, it doesn't mean you can't get pregnant. It just means you're not getting pregnant. And the purpose of our therapies is to expedite it, to increase the odds. So for that diagnosis, medicated insemination, where you're going to take a fertility drug, say like Clomid, and combine it with insemination, over 2 or 3 cycles, it increases the success over your natural fertility. But after 2 or 3 cycles, the success rates decline, and then you move on to IVF. So for the classic case of unexplained infertility, 2 or 3 cycles of insemination, then go on to IVF. For same-sex couples or single women who are doing donor insemination, who are having regular periods and are presumed to be fertile, typically you can do 6 to 12, depending on their age, inseminations before you move on to IVF, because they'll have a reasonable chance of getting pregnant without having to resort to IVF. So it's kind of based on the situation, on how you'd want to proceed. Eileen, I miss you at Boston IVF. Eileen, one of my nurses, sending a shout out. She's the best. Okay. Interesting question from Kay. Kay says, do you believe that the type of protocol and trigger shot changed the quality of the egg? I'm almost 42. How many embryos are expected to be normal? Okay. I don't think the quality of eggs are going to be changed by the type of protocol or the trigger shot. I think a patient has variability in her responses, and you want to get the best protocol that yields the most eggs without yielding too many, because if you yield too many, you get quantity at the expense of quality. But those eggs lead to the best embryos, and unfortunately, Kay, you don't know that until you do the treatment. So you see a patient, you look at her age, you look at her ovarian reserve, you look at the big picture, and you say, okay, I'm going to try this protocol. And maybe it didn't work well, and you try something else that works better. It doesn't mean the physician prescribed the wrong protocol first. He or she just didn't know which is going to be the best until he or she sees how you respond. Okay, in terms of how many embryos are normal, what Kay is asking is, okay, if you were to check the chromosomes of these embryos at age 42, how many of them are going to have a normal array of chromosomes? In a nutshell, more of the eggs we produce as we get older have abnormal chromosomes. So therefore, in the setting of IVF, more of the embryos we produce are abnormal. And at age 42, you should expect the embryos you create, at least 50% will be abnormal. If it's an IVF cycle where you got only a few embryos, they might all be abnormal. But it's so variable. So if you have a normal ovarian reserve, and therefore you know you can respond to treatment, sometimes you'll get a normal embryo in that first cycle. You might get 2 normal embryos. Sometimes it takes more than 1 cycle. So that's how you have to look at it. So it's not so much that the egg quality is impacted by the trigger shot and the type of medication or protocol. It's just the variability that each protocol confers that you have to assess. And you can expect 50% of the embryos to be at least abnormal. Shannon sends me the best Christmas cards. And it's great. Spectacular family, very blessed couple, and I'm honored to know them. That's awesome. Hi, Michael. Kristen. Kristen says that her wife and she are looking forward to connecting with our center up in Portland, which is a great center. Ben Landon, my partner, is heads it up. And do we coordinate with specific sperm donor centers? We give you a list of the best. And what I mean by the best, the ones that are federally regulated, who've done the most research on the donors, that have done all the appropriate quarantine for the sperm and are reliable. So we don't have any particular fiduciary relationship, but we're going to refer you to the best agencies that are out there. They're pretty much nationwide. Michael, is it true that blood O have low egg count and hardship with fertility? Not that I know of. I have not seen that data. Danielle, hi. I just saw you today. Jen, in terms of how many cycles a healthy 43-year-old woman should pursue before she suggests stopping, I would never, ever do more than 6. because I would have data to support doing it. Unless the patient's not responding well, I wouldn't put her through 6. And or if the patient psychologically needs to take a break. Sometimes all it takes is to have the doctor say, you know what, I think it's time to take a break, because patients are afraid to say it. They're afraid to hear it. And sometimes they need to hear alternate approaches are, are better. But the bottom line is I would never do more than 6. It would require that you still had a normal ovarian reserve. And certainly, if you weren't responding well or you were psychologically spent, I would consider an alternate approach such as donor egg. Brooke, that's a hard question to answer on what the recommended protocol would be. An AMH of 0.8, so Brooke is asking about a blood test that reflects how she would respond to IVF treatment. And endometriosis, yes, that's a borderline ovarian reserve assessment, but when you look at the ovarian reserve, it's not just about the quantity of eggs you get, it's the quality of the eggs. And the beauty of being 30, even though you might have borderline ovarian reserve testing, your egg quality is not like a woman who at age 40 has a borderline ovarian reserve. And the protocol is the one that is going to give you a good amount of eggs that create a good amount of embryos. And so there's 2 types. One's called the antagonist protocol. One's called the microdose flare. Typically, I start with the antagonist protocol because it's simpler, and I bet it would be effective because you are only 30, and that's in your favor. Question from Judy. If a patient has her tubes tied, what process do you guys do? Well, the vast majority of women who have their tubes tied, especially those who might be more of a more advanced age, do not benefit from trying to put the tubes together. Now, I haven't tied tubes for years, and this is since I was a resident when I was in private OBGYN, but typically the way the tubes are tied prevents them from being put back together. So it's far better for those patients to go through IVF so they can overcome the impact that the tube tying has. So it's rarely that a patient is a candidate to have her tubes put back together. Christine, thank you. It's very sweet. Jen asked about the different protocols that are available, and she's giving the names: the patch protocol, the estrogen patch, the birth control pill, Lupron. Jen, it's all dependent on the patient's ovarian reserve, how much her hormones have to be suppressed before you start the injections, and in terms of the dosing of the medications, again, the age of the patient and the ovarian reserve. So it's not just one templated protocol for every patient. The older the patient, typically the higher the dose. The older the patient, typically you want to lead in with either an estrogen patch or 10 days of the birth control pill or do the microdose flare. The younger the patient, they more often need the birth control pill to suppress their hormones before you start. So it's based on the diagnosis, the ovulatory pattern of the patient, and her ovarian reserve assessment. I have a question from someone who's had a partial hysterectomy. She has her ovaries, and I think she wants to consider using her ovaries for IVF to create embryos for her wife. The odds of that being successful is going to be based on the ovarian reserve. At age 41, there's at least a 50% chance that the ovarian reserve is going to be low and you won't be able to produce enough embryos to transfer into the uterus of your wife, but there's a 50% chance you will. And it's going to depend on the testing that's done to assess that. Thank you. Thank you, Tamara. Thank you, Tamara. Thank you, Janine. Thank you, Barbara. My God, this is amazing. Keela, your question is, how do I work with patients with Klinefelter? Klinefelter syndrome is something I see very, very frequently. For those who are the uninitiated, Klinefelter syndrome is a type of chromosome syndrome that impacts men that basically reduces their spermatogenesis, meaning their ability to produce lots of sperm. So the sperm is not present in their ejaculate, but the sperm is present in their testicles. And we can retrieve the sperm working with the urologist that we work with to get the sperm and freeze it to be used in IVF. And I do that so frequently. It is one of the most common reasons we do IVF. So the number one reason patients need IVF is due to the male. That's the most common single diagnosis, that men have low sperm counts, and those low sperm counts mean they're not going to get their partner naturally pregnant, so they have to do IVF. And the most common genetic cause of no sperm is Klinefelter. So it's very common. We do it all the time, highly successful and very rewarding. Michael, what does insemination mean? Insemination is a process by which we take either frozen sperm or we take a fresh ejaculate and we separate the sperm from the semen, concentrate the sperm and flush it into the uterus. That's called intrauterine insemination. Susan, thank you for the shout out. Ralu, just call the office. I don't even know what that NPI is. That's something from my admin. If you call my admin, she can get you connected for an appointment. Be glad to help out. Courtney, I'm very sorry to hear about your circumstance. That's there's no words. I'm so sorry. Your question about gender selection, is it more costly to try for twin boys as opposed to doing a single embryo transfer? So when you're doing gender selection of embryos, you're checking the chromosomes, and by so doing, you're increasing the ability, because you've made sure the chromosomes are normal, that an embryo is going to implant, and you're going to enhance the chance of achieving a live birth. So when you're doing that genetic testing, you don't have to transfer more than one embryo, and it's highly recommended that you don't transfer more than one embryo. The risk of twins are not inconsequential. So certainly when patients get pregnant and they have a spontaneous twin conception, it is what it is, and they have to accept those risks. But when you have this level of control, we really want to mitigate the risk of twins, because our concern is the risk of preterm birth and the lifelong consequences that ensue, such as cerebral palsy. So the question is, if you've checked the chromosomes, you can maximize a live birth with a single embryo as high as 70%. And as opposed to doing two that have been chromosomally tested, we really are reticent to do that. Thank you, Cheryl. Thank you, Janine. God, this is embarrassing. Shar, it says I skipped your question. I apologize. I don't know if I saw it. I think I did answer that question. That was the question about at age 41, helping your wife conceive. So it looks like we're getting into the Mutual Admiration Society, and an hour has actually passed. So I think at this point, I want to thank everybody that took the time to come on board and listen to me talk. I could drone on and on about this process because building a family is what I love to do, what I'm honored to do, and I've certainly learned a lot more from my patients than I could ever teach them. So I wish everybody the best of luck. Thank you, everybody, for the shout outs. Everybody stay safe and socially distant. What better way to be socially distant than this? And I look forward to seeing any one of you if you need our help in your journey to build a family. Thanks. Bye bye.